This set of notes will cover the major topics in cancer that we're going to talk about in biomedical science. And this corresponds with the last part of your Cell Molec Part 2 notes, and will hopefully help you as you begin working on your Cancer Grand Rounds research project. So many of the things that I'm going to talk about in these slides you might run into in your research, and hopefully this will just help clarify parts of it. So the slide here says, as we said a moment ago, but as you will see in the cell cycle notes, uncontrolled cell growth or out of control cell division is a really bad thing. And ultimately that is what cancer is. Cancer is a situation where the cell begins to divide too many times and you end up with way too many cells. And when those checkpoint controls that should keep track of cell division get damaged, a cell repeatedly divides to form a mass of cells called a tumor. Now, as a tumor gets bigger and bigger, it has the potential to interfere with surrounding tissues, maybe even to break off and invade some of the other tissues that are there, and that's why they can become damaging. But what's a little bit interesting is a lot of times a tumor or a cancerous growth doesn't really do anything to you. It's just that it gets in the way of your normal tissue. So if you take a look at this picture, all right, this is a CAT scan or a CT scan of the brain. Clearly, this big dark spot isn't supposed to be here, right? And that's a massive tumor. But think about what that's doing right now to the brain. All right, the brain is in an enclosed space, the skull. And so all this pressure that this places on this part of the brain, that's what's going to cause a lot of detrimental symptoms and potentially something that becomes lethal for this person. Now, tumors can appear as one of two types in a patient. The first type is called a benign tumor. And benign tumors are going to grow really slowly. They're going to still look and sometimes even function a lot like the tissue they came from. So if it's a lung benign tumor, it might still have some of the capabilities of lung tissue. And we say that a benign tumor is non-invasive. And what that means is that the tumor is not going to break off cells and send them out to invade other tissues. If you have a benign tumor, the doctor is probably not going to say that you have cancer. Because a benign tumor, you can usually treat, you can cut it out, or you might just be able to leave it alone and it won't really hurt you. The bigger concern is the other type of tumor called a malignant tumor or a malignancy. Malignant tumors are sort of the opposite. They grow very quickly. They do not resemble original tissue and do not perform original functions, and they can become invasive, meaning they invade other tissues and they spread throughout your body. Obviously then, if you look at those characteristics, malignant tumors are going to be a much bigger worry, and they can cause a lot more damage, and they're much more likely to be an issue for someone and potentially something that can lead to death. Benign tumors can become malignant tumors if you don't watch them, though. So again, a doctor might not tell you you have cancer yet. They might just tell you you have a growth if you have a benign tumor, but they're going to want to watch that and have you watch that so it doesn't become malignant. Now, we often name tumors based on the type of tissue that they come from, and then we put the suffix "oma" at the end of it. So just a couple examples here, but you might run into some of these kind of terms. An adenoma. Right? An adenoma really is a cancer that comes from any kind of gland. So if it comes from a gland in your body, they might call it an adenoma. Carcinoma. Carcinoma is similar. Carcinoma usually indicates malignancy. So they might say that you have a hepatic carcinoma, and that would mean that you have a liver cancer that has become malignant. Melanoma is a cancer of the melanocytes, which are your skin cells, or some of your skin cells. So melanoma would be a type of skin cancer. Lymphoma is a cancer of your lymphatic system, or your lymph and lymph nodes. Lipoma, right? We've seen that LIP before, lipid. Right? So a lipoma is a tumor that develops from fat tissue. And there's just tons of other names out there that you're going to see in your research. A couple pictures here. This one on the left is actually a section of colon taken out of a person. you see these dark growths. These would be pretty severe polyps that are definitely probably have gotten to the stage of being cancerous. Also, this is probably a tear in the lining of the colon or large intestine, which could possibly be when they tried to take this out, but also could be from sort of some ulceration or some damage to the tissue around those cancerous spots. Then here on the right is a microscope image of what this would look like. And on the last slide I mentioned that a benign tumor, the cells might still resemble the tissue they came from, whereas a malignant tumor, they would look different. In this slide, it's really easy to tell. All right, these patches of cells here that I'm kind of circling in red that look different. Right, these are cancerous cells. These are malignant cells compared to the other cells around here, which are normal, smooth muscle cells of the colon. So just a couple little aspects to look at this further. Now this picture here is probably my favorite picture that I made for Dr. Wong when I worked illustrating his textbook. And I called this Metastasis Man. And metastasis is when cells break off of a tumor and spread throughout the body. They travel in your body to another area. And they may travel via your bloodstream, or they may travel via your lymphatic system. But in any case, metastasis is a bad thing. Now, other terms you might hear, other versions of this word, are that a cancer has metastasized, or that cells have become metastatic. And in any case, this means that the cancer has moved. This is a challenge because if a cancer becomes metastatic, it becomes much harder to treat. Right? And generally, metastasis is what becomes responsible for cancer-related death. So not that a tumor in one place can't hurt you, but if you have a tumor in multiple places, it becomes a bigger issue. So what this picture is trying to illustrate for you is that colon cancer here in the large intestine, represented by like the solid yellow dot, colon cancer is known to become metastatic if it's not treated early. And the three most common places that you see colon cancer metastasize to are the lungs, right, the liver, and bones. And so what we might say then is this person had a primary cancer of the colon, and now they have a secondary cancer in the lungs or a secondary cancer in the liver. And again, this is a much bigger issue now because it's going to be much more difficult to treat. Okay, so there are lots of reasons that you might get cancer, right? Lots of different causes out there. Many of them aren't really proven, but there are some things that we know will cause cancer, particularly environmental things like UV radiation from a tanning bed or cigarette smoke. But ultimately what happens is if a cell becomes cancerous, it is because of mutations, right? A problem in the DNA. And so we will get into genetics a lot more next semester, but hopefully you recall from freshman biology that a mutation is a change in the genetic code or an error in the genetic code. And sometimes these mutations can be bad, right, and cause us problems. Every one of us experiences tons of mutations basically every day. Because if you've got cells dividing, like we do in certain places of our body, you're going to make mistakes, and you're going to have those mutations show up. Usually, our body is able to repair those mutations. So whether you actually fix the cell, or in some cases, you just remove that cell before it can become a problem. But sometimes that doesn't happen. Sometimes we don't fix those mutations, and those eventually can become a cancer. Now, before you freak out too much right away, thinking, oh my gosh, I'm full of mutations and I will be cancerous tomorrow. Cancer actually requires an accumulation of mutations. So a cell that has a single mutation is not going to cause cancer, at least none that we know of at this point. But if you have several mutations that add up in a cell, that's how it can become cancerous. So if you look at this picture, every one of these things up here are different genes, and don't worry, you don't have to know what these really are, that become damaged. And so a cell requires the adding up of a bunch of mutations before it really becomes a problem cancer. So for instance, we start with a normal colon cell. We have this first mutation occur. It's going to give us maybe a little bit of increased growth, but nothing that's detectable or anything yet. Then maybe months or even years later, this cell picks up another mutation. And that turns it into sort of an early benign growth. Then maybe you get a third mutation. And again, this might be years after the first one. And that's going to give you a little bigger benign growth. Then we got a fourth mutation that occurs, and you get to a rather large benign growth. Then you have this fifth mutation, and we'll talk about this particular one here in a second more, that might be like the last line of defense, and that leads you to carcinoma, a malignancy. Right? And then it might require a couple other mutations to occur for that malignancy to become metastatic, where it'll travel throughout, spread in your body, and again become something that's a little bit worse and a bigger concern. Now, mutations in two different types of genes in particular can lead to cancer. The first one here is referred to as a proto-oncogene. Proto, the prefix kind of meaning before, right? And then onco, the prefix referring to cancer. So before cancer gene. So proto-oncogenes are genes that generally promote cell division in a good way, when we need cell division to occur. But if these proto-oncogenes get mutated or messed up, they can become oncogenes and become too active, right? And then those oncogenes are pushing cell division too much, and you don't have control of it anymore, and you get too much growth. Now, the other option is a tumor suppressor gene. Tumor suppressor genes normally suppress tumors. So these normally are there to stop a cell from becoming cancerous. What happens in these guys is if we mutate a tumor suppressor gene, it no longer does its job. So it no longer stops the tumor from developing and allows that cancer to start dividing uncontrollably. Now, the most important tumor suppressor gene, really the most important mutation of all that we're aware of, is a mutation in P53. I'm not real sure what Samson's picture has to do with this. It's a funny picture. P53. P53 is a gene that under normal conditions keeps your cells from becoming cancerous. So P53 limits the cell cycle. It stops the cell cycle if there's a mutation or some other problem going on in that cell. But if P53, the last line of defense, gets mutated, then it's no longer there to do that job. It's no longer there to defend against cancer, and the cell can become cancerous. So you can kind of think of P53 as like the goalie in soccer, right? It's the last person that can block the other team from scoring. If you take the goalie out, now there's nobody there to block it. And so normally this P53 will block cells from becoming cancerous, but if P53 gets damaged, it can't do its job, and there's no stopping that cancer then. Two other examples of tumor suppressor genes that you might want to be familiar with are BRCA1 and BRCA2, which is breast cancer 1 and breast cancer 2. These are two different tumor suppressors that are responsible or play a role in a lot of different types of breast cancer. And just like P53, these are tumor suppressors. So normally they function to keep your cell from dividing out of control. But if they are mutated and they no longer do their job, then the cells can start to divide uncontrollably. This is just a picture for breast cancer. Here on the left, you've got a mammogram, which we'll talk about more here in just a second, which is a way to scan the breast tissue. And they've highlighted in this picture this little interesting growth there. Not to say that this is a cancer or a tumor, but it's maybe something that's out of the ordinary. What doctors will tell you today, though, is that a mammogram is really not the best way to image a breast cancer patient. Mammogram is usually where we start because it's cheap and easy. But if somebody has a history of breast cancer, if somebody has a really strong family history of breast cancer, or in the event that a mammogram turns out kind of out of the ordinary like this one, then the doctor would probably call for an MRI of the breast, which gives you a much more detailed picture. I'm certainly not an expert in these, so I don't really know if there's something abnormal about this one here in the picture or not. But if you did see a mammogram like the one on the left, then you would call for an MRI, which would give that doctor a much better view of that tissue to try to seek out those tumors that could be there. There's another Superman Samson picture. One thing that I used to not talk about in the notes, but that lots of students would ask about, so we got into it a little bit more, is how to diagnose cancer. And the fact of the matter is there's no single test that can accurately diagnose any type of cancer. There's not really a cancer test. And even if there was a cancer test for one type of cancer, there's a whole bunch of other types of cancer. So to try to get to a cancer diagnosis, you have to do a really complete evaluation, right? You need a very complete patient history, like we've talked about some in class. Really need all that background information, need a lot of information about the patient's family as well. You would also do, obviously, an exhaustive physical examination on that person. And then there are lots of different diagnostic tests that you might use to try to tell if something is cancerous. Ultimately, what our goal is to rule out other things, right? Cancer is a pretty serious diagnosis. So what we want to try to do is rule out all the other options first to try to identify a cancer. If somebody just has some kind of infection that we could treat with an antibiotic, or if somebody just has something else going on that's maybe a little simpler, we'd like to know that and not tell a patient that they have cancer and be incorrect. So you definitely want to run plenty of tests and be real sure about this before you go there with your patient. Now, the first thing that we would use would be clinical chemistry tests, right? Looking at body fluids, basically, from a lab perspective. And these can include a few different things. First, it could be a blood test, right? Some of you guys have probably had blood drawn before. Really common blood test we might use is a CBC, or complete blood count. CBC is going to look at the size of your red blood cells, and white blood cells is going to look at how many of those cells you have. It's also going to look at the maturity of those cells. So basically, if you have an issue going on, you might have some immature red blood cells in your bloodstream or something. So that's what that looks for. We're not going to go into too much detail about what you're looking for there, because different disorders can give you a lot of different outcomes for CBC. Another thing that we look at in the blood is the BUN, using a BUN test or a creatinine test. BUN stands for blood urea nitrogen. Creatinine is a different but similar test where we're looking for excessive wastes in the blood. If a BUN comes back high or creatinine comes back high, it might mean that your kidneys are having an issue getting wastes out of your body, or it also might mean that there's some weird damage somewhere with tissues. For instance, something like a heart attack can actually raise your creatinine levels. So these two, and we're not going to really talk about what a particular result tells you, because they can tell you a lot of different things. Then we've got urinalysis, very simply a test of the urine, right? They'll have you pee in a cup, and the initial thing is they'll use a dipstick like the one in this picture, and they can test for all kinds of things. They can look for bacteria, they can look for proteins and carbohydrates and all sorts of things that we would expect certain levels of in your urine, and if those levels are off, then we got to try to figure out why. Another clinical chemistry test that you would look for using really blood or urine is a tumor marker test. Now, tumor markers are released by cancerous cells into your body or generated by the body in response to a cancer somewhere inside there. This sounds like a great thing, right? If we can just do a test for a cancer marker or a tumor marker and it's positive, well, they have that tumor. But it actually is not a real perfect test. A lot of people who do have a tumor don't really have tumor markers, and some people who don't have cancer and have more of a benign disease will have those types of tumors, or rather tumor markers in their body. So these are chemicals that will show up if you have a type of cancer, but sometimes they show up for other reasons too. So for some examples here, PSA, or prostate-specific antigen, this is high in older males who have prostate cancer. And so this is a test, it's actually probably the most reliable tumor marker test that's out there right now, is if an older male has a high PSA, you can assume that they have prostate cancer. AFP is another one we look at. It stands for alpha-fetoprotein. But a raised alpha-fetoprotein could indicate a cancer of the liver, a cancer of the ovaries, or a cancer of the testes. So there too, yeah, it might be a good indicator of cancer, but it doesn't tell you what type the person even has. Then we've got a third one here, HCG, human chorionic gonadotropin. which has an even bigger list. Right? HCG levels will be raised in somebody with testicular cancer, ovarian cancer, liver cancer, cancer of the stomach, cancer of the pancreas, and cancer of the lungs. But here's the kicker, right? AFP and HCG also are raised by pregnancy. So if you have a woman with a really high HCG level, it could mean she's pregnant or it could mean she has cancer. And those are two very different things, right? And two very different diagnoses that you would give a person. So again, tumor markers are not always your best test to run, at least not the most dependable. A lot of different scans can also be helpful in diagnosing cancer, and we're going to have some information on radiology, which is all the different types of scans, in the second semester, and go into a little more detail with some of these. But for now, some of the things that doctors can call for as tests. You've probably heard of ultrasound before. Ultrasound uses sound waves to produce an image. This is very safe for the body, so we use ultrasounds for pregnant ladies, but you can also use ultrasound for soft tissue areas. If you think somebody has a stomach cancer or something like that, you can use an ultrasound to look at that. X-ray also works. Right? X-ray is the best way to look at bones in the body, probably. So if you have a solid structure, you think there's some sort of growth there, you can use an X-ray. Mammogram, we mentioned a little bit ago, mammogram is technically a specialized X-ray that is used to look at breast tissue. Then we got CT and MRI. CT and MRI are unique because they sort of like digitally section the body. So they digitally, like with a computer, slice you up into a bunch of different slices. And then you can look at each slice. And it gives you almost an interior look at structures of the body. So this up here is an MRI. This up here is an MRI of the head from the side here. And it's just like we can look inside there almost using this type of scan. So these are going to give you really nice detailed images. Then we have PET scans. And these are the only one on this list that are actually kind of specific to cancer. PET stands for positron emission tomography. But this is where you actually inject a radioactive tracer into someone's bloodstream, and then you can watch it with the right kind of computers and the right kind of software. So this would be a black and white version of a PET scan. This would be a colored with a computer version of a PET scan, where we're just looking to see if certain organs light up, and if certain organs do light up or don't light up, that might be indicative of a certain type of cancer. Last thing here when we talk about diagnosing cancer is cytology, which is an extremely useful test because you can actually study a cell or a group of cells from an organ. And if you can obtain a group of cells from an organ, then you can have a pathologist or an expert identify whether or not those cells are cancerous by looking at them under the microscope. So a really common thing that's done if someone is suspected of having lung cancer is called sputum cytology. And that's where you collect some of their mucus when they cough, sputum, and then try to look at that in the laboratory and look for cells in that mucus. Because a lot of times people will expectorate or cough out cells, and they could be cancerous cells if they have a lung tumor. The other thing here that's a little more general is a biopsy. Right? Many of you are probably going to see this in your research. Biopsy is a medical removal of a tissue or cells from a living person, right, to take that little sample out and look at those cells to try to detect the presence of a disease. So this could be a larger cut of cells from somebody. Anyone in here who maybe have had a run-in with a skin cancer issue, a mole issue with a dermatologist, they often do a little slice where they take a really thin slice of your skin and they do a biopsy that way. It's usually called a shave biopsy. Or in an internal setting, a lot of times we take a needle biopsy. And so this picture up here is a CT-guided needle biopsy of the lung. So if you see what's going on here, this is actually like a CT scan that's going on live and the doctor's watching. And then he is putting a needle through the ribs into the lung that has like a little hook at the end. And he can grab some cells from this kind of irregular looking area of the lung and then pull it back out. Obviously, they would put you under for this. This would not feel good at all, and probably has some pain after the procedure as well. But overall, it's not real harmful to you. It leaves a very small incision in your chest. and removing that little small number of cells from the lung isn't too damaging. But then it allows them to really examine those cells and be able to tell if they're actually cancerous or if the growth is more of a benign thing that's not as big of a concern. Now, in terms of treatment, you're going to see lots of options out there too. Some treatments are better than others in terms of the options and the type of cancer you have, but you're going to see some kind of reoccurring themes. So the first big one is surgery, right? Trying to cut out the tumor, remove the tumor, and remove that cancerous tissue. If you have a solid tumor, this is very effective. And if you have a tissue that you can get to and that you can cut part of out, it's also very effective. For instance, if you have a tumor in your kidney and we can go in and just remove a small piece of the kidney, that can be really effective, and it can get rid of that cancer, and the remaining kidney that you have there can still do a good enough job for you. Surgery can be really helpful, but it also is almost useless when you have metastasis. So if cancer has spread to other parts of your body, there's almost no reason to cut it out of one part. The other problem here is that you do surgery, you're going to damage some healthy tissue, right? You're going to have to cut through some things and whatnot in your way to get to that tumor. Now, the second thing that I'm sure you've heard of before is chemotherapy. A lot of times people are surprised to find out, though, that chemotherapy is just medicine. It's just drugs, chemical therapy. So these could be pills that someone takes, or more commonly, they're IV drugs. You have to be hooked up to an IV, and they're given to you intravenously. Chemotherapy can be really effective. It affects your whole body, but it will hopefully target the cells that are rapidly dividing, which would include those cancer cells. The problem with this, or the big side effect from chemotherapy, is it also has a detrimental effect on areas of your body that are supposed to be rapidly dividing. So for instance, your skin. Right? Your skin should constantly regenerate itself. So if you have chemotherapy and it has some damaging effects on the skin, you're going to see dry skin, you're going to see skin that might crack or be a little more fragile. You're going to see hair loss from that skin, which is a really common side effect that people know of for chemotherapy. You also have to constantly do cell division in your digestive lining. So people have digestive issues, they'll have nausea, they'll have vomiting and things as a side effect. You also need your immune system to constantly be making new cells. So people undergoing chemotherapy have problems with their immune system working very well, and they have to be real careful who they're exposed to so they don't catch illnesses from other people. So again, drawback to surgery and chemotherapy is that you end up damaging healthy tissue as well. Third one's radiation. You probably heard of this too. This is where you direct energy, radiation, at an area of the body where there's a tumor in hopes that you can shrink the tumor and kill the cancer cells. Now, what radiation will do is it will damage the DNA of cells and hopefully keep them from multiplying rapidly. Radiation is a lot better than it used to be. It used to be that we radiate people and we actually end up causing DNA damage that leads to other types of cancer. But now you can get really, really specific with the area of the body that gets irradiated. And it's kind of cool how it works, because even if a healthy cell gets damaged, usually a healthy cell can repair itself. But a cancerous cell doesn't seem to have those repair mechanisms in line. So if we damage the DNA even further in a cancerous cell, it usually causes that cell to die. Again, here's this risk of side effects from damaging healthy tissue, though, with radiation therapy. Now, your fourth one is referred to as targeted therapy, and this is sort of like a general term for any kind of new experimental treatment that focuses on a specific type of cancer or specific type of cancerous cell and tries to attack characteristics of that type of tumor. There's a lot of options out there right now, but most of them, like I said, are experimental and sort of in the test stages. One example that is actually used now more is a drug that will cut off blood supply to a tumor. Believe it or not, when a tumor grows, it oftentimes makes your body form new little blood vessels that'll bring extra blood flow to that tumor. And so they've come up with drugs that will actually go in and kill those little tiny blood vessels off and destroy those, because then if the tumor cells don't have enough blood supply, they don't have oxygen, they don't have nutrients, and those cells can die off. Now, ultimately, doctors prescribe many different approaches to treatment. So a lot of times you're going to use these in conjunction. So you might even know somebody who had to have radiation and chemotherapy, or they had surgery followed by some chemotherapy, or they had radiation to shrink a tumor and then they had surgery to remove it. And so usually patients don't just have one of these. If they have a cancerous case, they're going to have several or a couple of these treatment options put into play. This slide is getting to be a little bit dated now. You'll notice this article is 2011, but this research is still ongoing for some really cool targeted therapy that would help treat leukemia, which is essentially cancer of the blood. What we see in someone with leukemia is an excessive growth of white blood cells that you don't need and that don't really work right. And so this new therapy that was kind of first written about 5 years ago now, but it's still kind of in the research stages, is a way to take your own T cells, which are your immune system cells, and kind of train them to specifically kill leukemia cells. It's a really wicked concept where we could take T cells, turn them into serial killers, give them genes that allow them to identify if a cell is cancerous or not, and then actually attack that cell and destroy it if it's a cancerous cell. If they can do that and they can get that to work really well, that might be a way to really efficiently get rid of leukemia in patients. Okay, so now we'll wrap up with just a couple of statistics, really. Some interesting facts. So cancer is the second leading cause of death in the United States after only heart disease. So that's a pretty big deal. It kills a lot of people. The most common cancers in women are breast cancer, lung cancer, and colorectal cancer, in that order. And the most common cancers in men are prostate cancer, lung cancer, and colorectal cancer, in that order. So your number one cancer in men, you won't see in women because women don't have a prostate. Your number one cancer in females, you rarely see in males because it's breast cancer. Do note what I put on here, though, especially if your group is researching skin cancer, you will see that skin cancer is one of the most common types of cancer, and that's true, but these statistics that I got here, this information that I got here, does not include the non-melanoma type of skin cancers. So since they get a little more specific, that reduces the number of skin cancer quite a bit. Number one cancer killer is lung cancer. So the most lethal cancer that we know of is lung cancer. And around here in Kentucky, we know that the number one cause of lung cancer is cigarette smoking. So, that is becoming less and less common, I think, especially in young people. So I hope that you guys keep that going because there's really zero benefit that you get from that. And an outcome that you can definitely get is lung cancer. Last little graph here I like. This is mortality data. So this is the number of deaths, basically the rate of death per 100,000 people for given types of cancer that you see over the past about 80 years. And so again, what you'll notice here, lung cancer has the highest mortality rate, highest death rate. But notice that some cancers we've gotten better at treating or curing, and they are on a downward trend in more recent years, whereas other cancers have been pretty consistent. I guess the good news is that these cancers that have been consistent do not cause a lot of deaths, but they continue to be the ones that are really difficult to treat. So pancreatic cancer is one of the hardest ones to treat and has a really high mortality, or has a really consistent mortality over the past several years. Liver cancer as well. You'll notice stomach cancer has gone way down because we've gotten much better at treating that. Prostate cancer, colon cancer, lung cancer have all gone down in more recent years as well as the treatment options have gotten better. So that concludes the CellMolec Part 2 notes, and it concludes our cancer discussion. Hopefully a little bit of this will help you with understanding and presenting your patients during the Cancer Ground Rounds project. And then this material will also be part of the CellMolec Part 2 test. So have a good day.